Hello everyone, welcome to Medica Cardio Talks episode 22nd. We are here today to discuss a very unique molecule which is not known worldwide, but it's available in India for many years and it has a real potential what we think. And we're going to discuss about the molecule and its possible use. And the molecule today we are going to discuss is Saroglitazar. So we have with me today Dr. P.K. Sethy. He is our Director of Gastroenterology and Liver Diseases.
Hello.
Hello Dr. Sethy. We have Dr. Rahaman. He is a Senior Endocrinologist at Medica Hospital. So to begin with, let me ask Dr. Rahaman, how does Saroglitazar act and what makes this molecule unique?
Thank you, Dr. Kumar. First of all, this Saroglitazar molecule, this is basically a PPR alpha and gamma agonist. Previously, we have this pioglitazar molecule, which is basically a PPR gamma agonist. And by acting on the PPAR gamma, the pioglitazar, it worked as an anti-hyperglycemic agent. It did not have any benefit in glycemic benefit or any other benefit in relation to metabolic liver disease or fatty liver diseases. Whereas this molecule Saroglitazar, which is a PPR alpha as well as gamma agonist, it basically acts on PPAR alpha and gamma, and basically it reduces triglyceride synthesis in the liver. It causes increased fatty acid metabolism and thereby reduced triglyceride synthesis and secretion. So thereby it also causes reduced fatty acid deposition in the peripheral tissues like muscle and fatty tissues, and it also releases more amount of fatty acid and supplies to liver. So there is reductions in the fatty liver component in the liver. It increases insulin sensitivity, it reduces insulin resistance, and thereby it has the metabolic benefit and it has a hyperglycemic benefit. And as it reduces triglyceride synthesis and it causes increased fatty acid metabolism, it has immense potential to reduce the non-HDL cholesterol. It reduces triglyceride, it reduces LDL, and it reduces VLDL also.
Great. So in nutshell, it increases the insulin sensitivity.
Yes.
Reduces insulin resistance. It reduces the triglyceride levels.
Yes, sir.
And non-HDL cholesterol. It basically acts on liver, and PPAR alpha has multiple distribution, gamma also multiple distribution, acts at very sites, but basically it reduces triglyceride. So may I ask Dr. Sethy, this Saroglitazar has been approved for some indications in liver disease like NASH, NAFLD or PBC. So can you just throw some light and tell us exactly how, what is the evidence and where do you place this molecule in your practice?
This molecule is available in India for quite some time. We are actively using this molecule in practice for the NAFLD and NASH. This molecule, it decreases hepatic inflammation, steatosis, and even liver fibrosis. And but I'll emphasize one point. Till now, the main point in management of NAFLD and NASH is weight reduction and exercise, and the medications comes second or third line. And this molecule is a great promising molecule. We have good number of trials from India, now few phase 3 trials from outside also. If you talk about trials, there is definite improvement in hepatic inflammation in the forms of improvement in SGOT and SGPT. There are some reports improvement in hepatic fibrosis also. So no doubt this has great potential, and maybe in the pipeline we have couple of other molecules for the fatty liver disease in the future.
So yeah, so I think wonderful. So it has got established role in liver disorders, and I look at two situations. One is someone who is diabetic. So India is a diabetic capital of the world, we all know, and soon going to be cardiovascular capital of the world. And we have many diabetic patients who have altered lipids, and the typical diabetic dyslipidemia is a low HDL and high triglyceride. And probably this molecule made to work on this pathway only. It reduces non-HDL cholesterol, reduces triglyceride. So this is one scenario where we are dealing with a diabetic patient with dyslipidemia, not low HDL, high triglyceride on statin. Still, you are not meeting the target. And second is someone who has a only high triglyceride of 600. So my first question goes to Dr. Rahaman. When will you place Saroglitazar after statin in those patients where triglyceride is still high, more than 300, 350, 400, highest dose of statin have given? Would you like to add uric acid derivative or Saroglitazar, which is going to be beneficial in diabetic patients? And then next question to Dr. Sethy, someone who has only high triglyceride of 500, 600, 700. Which drug you are going to give first, and does Saroglitazar comes as a second line drug, or where do you place it, second or third or fourth line drug? Dr. Rahaman.
Thank you, sir. Nice question. Saroglitazar basically it fits in diabetic dyslipidemia. What happens in diabetic dyslipidemia? There is typical high LDL, low HDL, and high total non-HDL cholesterol, and high hypertriglyceridemia. So, if we use this Saroglitazar molecule, there is reduction in the LDL, there is reduction in the triglyceride, and there is improvement in the HDL, and there is reduction in the total non-HDL cholesterol. Simultaneously, we get benefit in our glycemic control also. So, studies have proven there is almost HbA1c reduction to the potential of 0.5% reduction of HbA1c. So, it is almost equivalent to gliptins. So sometimes it's almost equivalent to SGLT2 inhibitors also. So with the added benefit of improvement in the diabetic dyslipidemia. So this is a very good drug for patients with diabetes, how you typically see diabetic dyslipidemia.
Many prescriptions we see, but
is it a first line drug for the triglyceride? I don't think.
So this is not a first line drug, but for a diabetic patient where there is all these problems, high LDL, high triglyceride, low HDL, and there is no other option to improve HDL cholesterol.
Once we given statin high dose and still it is not coming up, Saroglitazar is a very good option because it also gives you benefit in glycemic control also.
And what about the triglyceride, very high triglyceride like 600, 800?
Yeah.
I think that the molecule is not so much indicated.
Again in the statin and followed by a Saroglitazar.
Yes.
Or
statin and
fenofibrate will have.
So
statin and fenofibrate.
The question comes from, I will tell you from where the question comes, because we see a lot of prescriptions and our prescription also where a patient, the so-called two situations we discussed, we never write Saroglitazar here. So is there any, something which we are missing, something which we have? I think intuitively we feel that if this molecule doesn't have much of side effects, it is a PPAR, alpha gamma both agonist with no liver toxicity, very mild nausea and vomiting like side effects, and it can reduce triglycerides in significant manner. It can reduce glycemic. It can help in glycemic control. It can increase insulin sensitivity. So with this, I think it should be maximum second line drug.
Even I was going through a recent trial, randomized controlled trial, comparing vitamin E with Saroglitazar for NAS. There is a definite improvement in the hepatic fibrosis, all the parameters of steatosis and inflammation. So no doubt this molecule has definitely a role for the management of NFLD.
So uric acid derivatives, you see so many combinations are there, statin or uric acid derivative. So they act there in liver, and chance of liver toxicity, myopathy becomes very high. So why not to add this drug and see, especially diabetic patients. So most of the patients come, diabetic patients with dyslipidemia, it really fits there, and that was basically the idea of our cardio talk and discussing this molecule, because it is not in practice of even our pain. It is not there when we write the prescription. It doesn't come in our mind.
But for hepatologists and gastroenterologists, we write we have quite good number of molecules for the liver, but this medicine is very promising and we write very frequently. So what about how long you give for this molecule? How long you give?
We give for 3 months and we see the response, and depending on that we continue or discontinue.
Same thing.
I have 2 more comments. One is this fenofibrate, statin and fenofibrate, and statin and Saroglitazar. So there is always a risk of increasing diabetes with the use of statin and fenofibrate.
Yeah.
Whereas this molecule is going to reduce insulin resistance and is going to improve the glycemic control. So there is a sharp benefit, sharp edge of this molecule over statin fenofibrate versus statin and saroglitazar. So one point. Number two, for isolated hypertriglyceridemia, many times we see with poorly controlled diabetes, HbA1c may be 9, 10, 11, 12, the triglyceride level particularly is very high, 400, 500, 600. I think in that case, along with insulin, we can use this molecule to reduce insulin resistance as well as to reduce triglyceride level. So it has a point to add in a patient with isolated hypertriglyceridemia in a patient with poorly controlled diabetes.
I totally agree with you. Wherever we are using statin with fubric acid combination, there is a chance of using this molecule with a lesser side effect, and maybe better outcome as well. But it seems to be with the evidence. And last question, both of you rather, do you feel that had this molecule been coming from US, outside, this molecule have been more prevalent and more used worldwide with more of evidence for it?
Maybe gradually they are picking up. They are doing some trials from outside in US. Maybe we'll have this molecule present in rest of the world also.
So it's available in Mexico, I think.
India and this part of country, this part of world,
and this part of the world, and Mexico it got approved. A year back probably, and in the case of PBC they are using. So with this, I think.
But the only thing we have to emphasize for fatty liver or for any related illness, lifestyle measures including exercise, weight loss, and control of blood sugar and thyroid is more important than medications.
Definitely.
So with this, we'll have feedback and input from our senior cardiologist, Dr. Rabin Chakraborty, and I hope this molecule, this worthy molecule, gets its due place in coming time, and we will explore more of its potential as well as its flip side if at all it is there.
So, on this 22nd episode of Medica Cardio Talks, you heard from my colleague Dr. Dilip Kumar, consultant cardiologist, Dr. P.K. Sethy, consultant gastroenterologist, and Dr. Hammadur Rahaman, consultant endocrinologist, about this new molecule called Saroglitazar, which is very useful drug in situations like diabetes and dyslipidemia, and therefore this molecule is extremely helpful in conditions like non-steatotic hepatosis or non-alcoholic steatohepatosis, cardiovascular disease, especially with dyslipidemia, where it reduces LDL and improves HDL, and of course in endocrinology, the diabetes mellitus and dyslipidemia. So I'm sure that their discussion on this molecule will open up a new window for understanding of management of dyslipidemia, especially in context with heart disease and in context with diabetes mellitus and non-alcoholic steatohepatosis. Please do let us know your opinion, your feedback, which is extremely important, and we'll come back to you again with our 23rd episode of Medica Cardio Talks. Thank you very much.